بسم الله الرحمن الرحيم. مرة تانية شكرا لدكتور خالد، شكرا دكتور وليد، شكرا دكتور مي طبعا على تعب معايا الفترة اللي فاتت عشان ننظم الجورنال ميتنج دون. Today's talk is about this paper that appeared recently in the European Journal of Nuclear Medicine in molecular imaging. And the primary reason for selecting this journal paper is that we are currently working on actually having preliminary data for a very similar work that involved FAPI PET imaging for liver fibrosis. And at the time we're preparing a manuscript, we start to look up more and more into literature. And we thought they're going to be the first to report on such an important topic. But interestingly, we came across this work from a very reputable Chinese institution that span not only the clinical translation, but also they have the preclinical data that was translated into clinical scenario. Before starting, we have a small disclosure. I'm going to be referring to some of the studies that were performed on total body PET CT, and the institution I'm working on, UC Davis, has sales-based revenue agreement with that company that manufactured the UX Explorer. The other disclosure is this going to be non-specialized brief overview of the liver fibrosis with a focus on a disease called MAS LD that we'll jump into momentarily. We will try to dissect through the non-invasive test using for diagnosing liver fibrosis and emerging pharmacotherapies that were very recently approved. Then we'll go through this journal paper and some of the relevant works at our institution. So probably we are all familiar with the two most common causes of liver fibrosis being viral hepatitis and alcoholic liver disease, depending on where you're living in this Mother Earth. But the shocking part that I just realized out of my probably ignorance or lack of connections with especially the hepatology and GIT, where we are in nuclear medicine, we are more familiar with oncology, probably cardiology and endocrinology as well, but little probably to do with the hepatology. I realized that the metabolic dysfunction associated steatotic liver disease, abbreviated as MASLD, is the most common, the leading cause of liver fibrosis at the moment. And that fancy name evolved from the well-known fatty liver. This dates back in the 1980s, described as non-alcoholic fatty liver disease, and in the presence of inflammation within the liver parenchyma, named non-alcoholic steatohepatitis or NASH. And slowly it was realized that this naming does not really capture all the phenotypes of this disease. And also this non-alcoholic part is more like a diagnosis of exclusion rather than telling what the actual cause behind it. So it was till 2020, they changed the name into metabolic dysfunction associated fatty liver disease, or MAF-LD. And that also didn't last long. Soon, 3 years later, it was changed to remove the word fatty and replace it with steatotic liver disease. And that's primarily because the word fatty probably is stigmatizing. And also it might be mixing etiologies in there. So across this world, across this current talk, we will be probably referring interchangeably to fatty liver, NAF-LD, MAF-LD, or MAS-LD. So it depends when was the publication made. So what's this MAS-LD? It is diagnosed by two criteria. Number one is the hepatic steatosis. And that's diagnosed on imaging or biopsy. And I take a moment here to remember, as a nuclear medicine physician, probably most of the audience, how many times we writing in our reports diffuse liver hypoattenuation, likely due to fatty liver. So it's quite common. And the other part is the presence of one of cardiometabolic risk factors. And again, take a moment to look at these cardiometabolic risk factors. They are quite prevalent and they are aiming to capture the disease very early. So BMI, for example, not in the obese category, but in the overweight category with more than 25 kilogram per square meter. The same for glycemic control. It's capturing the pre-diabetes. Blood pressure, more than 85 diastolic. And if you look in here as well, they look at the high plasma triglycerides or low HDL, low good cholesterol. And these criteria are approved by both the American Association of the Study of Liver Disease and the European and Latin America counterparts. So with that diagnosis, with this criteria, MASH LD represent a silent global epidemic. 1 in 3 worldwide probably are suffering from this disease. And that percentage even like doubled in patients with type 2 diabetes. So with that current rate of increased obesity and diabetes, it's projected that we will have more than half of the world population suffering of MASH LD by the year 2040. And you can expect the cost to any healthcare system here per year in the United States more than $100 billion. And you might think that it's a benign disease and we don't know exactly this, if it's causing anything, but actually this is not true. The age standardized death rates attributed to MASH LD are quite staggering worldwide, with Egypt, unfortunately, among the leading high death rate per 100 population, 14 deaths per 100,000 population. This is the highest in the world almost. So this is not surprising if we consider the natural history of MASH LD. So that disease started by simple steatosis, but in up to 40% of people that have fat liver, that's defined as more than 5% of hepatocytes having fat included, and up to 40% are changed into or develop a phenotype of the disease called MASH. This is the inflammatory counterpart. And as inflammation is there, you expect also fibrosis to start taking place. Up to 25% of this will progress to even cirrhosis. And among this cirrhotic part, 7% will develop hepatocellular carcinoma. But that's not the whole picture. Up to 30% of MASH LD related HCC occur without cirrhosis. So even cirrhosis is not a prerequisite to develop hepatocellular carcinoma in that disease. You might think that, okay, this is quite a indolent course, can take up to 6 or 7 years to transition from one stage to another. But in the presence of risk factors, specifically obesity and type 2 diabetes, the disease progression could be accelerated tremendously. And it's not only limited to the liver. There is up to 60% increase in the fatal and non-fatal cardiovascular events, and increase in the chronic kidney disease, and surprisingly, there's also a surge in the extrahepatic cancers. So how that all occur? How does take place? The pathogenesis behind this disease is quite complex, and I'm not sure it has been really fully elucidated yet. There's inter-organ crosstalk taking place primarily between the adipose tissue, muscles, and gut, and these send cytokines to the liver, causing liver stress and hepatocytic injury. If we remember from the histology, the hepatocytes are lined along these sinusoids. So the apical part of hepatocytes have a little bit of a space separating it from these blood sinusoids. And in that space, called the space of Dicey, there's two important cells in here. One is the hepatic stellate cell, and the other one is Kupffer cell. And that hepatic stellate cell is the first to sense the hepatocytic injury and sends signals to this Kupffer cell to activate it. And Kupffer cell will subsequently recruit more macrophage into the place, and this macrophage will activate the hepatic stellate cell. This is the key step, key milestone in the progress of hepatic injury, because the activated hepatic stellate cell is actually a transdifferentiation, or basically this cell that used to have only vitamin A storage and nothing else, it is now a myofibroblast that will start laying down extracellular matrix, and that will maturate into fibrous tissue. So what's the role of Fab in all that? Fab is the abbreviation, as you know, for fibroblast activation protein. And it is normally minimally expressed in normal liver, but this activated hepatic stellate cell will express Fab in large quantities. And it has been shown that Fab expression correlates with the degree of fibrosis, and also Fab has a very prominent role in promoting inflammation, and blockage of that Fab molecule will lead to a reversal of the fibrotic process as a whole. The other part of the mechanism for Fab is that it is the inhibiting fibrinolysis. We know that plasmin is there checking the transformation of fibrin into basically fibrinolizing the fibrin and causing scar resolution. And that's underchecked by alpha-2 antiplasmin. That alpha-2 antiplasmin is tremendously becoming more potent in the presence of Fab. So basically, this will uncheck plasmin and favor more scar formation. All this makes Fab is a potential good diagnostic and therapeutic agent. So how this MAS LD is diagnosed? The reference standard for diagnosis is histopathology, and it's considered non-optimal reference standard, as we'll see later why this is the case. There is on histopathology, there is a scoring system called NAV-LD activity score. Again, this is the old name, abbreviated here as NAS in here. NAS is formed of 3 domains: the presence of steatosis, grades 0 to 3, lobular inflammation, grade 0 to 2, hepatocellular ballooning, which is an index of hepatocytic injury or liver hepatocyte stress, also scored between 0 and 2. And also there are 4 fibrosis stages, depending on the amount and location of fibrous tissue between stage 1, 2, 3, with stage 4 representing frank cirrhosis. This is quite important distinction is that the MASH or NASH, the inflammatory phenotype of that disease, of the fatty liver disease, is primarily defined on biopsy, and there is no other method right now capable of this diagnosis. So why we mentioned that the biopsy is not optimal reference standard? Of course, this is a liver, so there is a potential for serious complications when you biopsy the liver. And also there is sampling variability, although this is mostly a diffuse liver disease, but there's potential also for sampling variability in there. And you always will assess like 1 or 2 locations within the liver at maximum. This scoring system is quite subjective, and there's considerable inter-reader and even inter-reader variability. So what's the alternative? The non-invasive diagnosis of this disease. Clinically, there's no real specific symptoms, mostly non-specific, usually discovered incidentally on imaging or lab check. There is a term called non-invasive test that we'll be using frequently for the remaining part of the talk. NITs are either lab or imaging, and they are aiming to diagnose the three hallmarks of this disease: the steatosis, the inflammation or MASH, the fibrosis part. So what are the available NIT for steatosis right now? We are familiar with the regular ultrasound, this basically black and white scanning of your body, looking at the anatomy and structure, but it is very subjective and not quantitative. And actually, the American Association of Study of Liver Disease does not recommend conventional ultrasound to diagnose hepatic steatosis. Alternatively, they recommend the FibroScan. This is like a commercial name for VCTE cap, or a controlled attenuation parameter in here, and that is quantitative for both fibrosis and steatosis. So take home here is that the MRI proton density fat fraction is the reference standard, and the recommendation is to use FibroScan to quantify and diagnose steatosis. This is a landmark paper in Nature Medicine that looked at probably 1,000 or more patients, and they are trying to find a non-invasive test to diagnose inflammation within the liver, the at-risk MASH or metabolic dysfunction-associated steatohepatitis. Nevertheless, from all these previous, as we know, when you find multiple tests for the same condition, it means mostly that none of them is perfect. And among all these, the AUC, which stands for the area under the curve, this is like a diagnostic indicator ranging from 0 to 1, with 1 being perfect. The diagnostic accuracy, overall diagnostic accuracy here, ranging to up to 8%, 83%. But there is a potential for an S4 to advance properly. And they stated clearly that there's no circulating biomarker could be diagnostic or surrogate for MASH at the moment. So what are the available NIT for fibrosis? So now we looked at steatosis, we looked at the inflammation. What the third component here is the fibrosis. There are multiple lab tests here in light blue are more simple kind of indices, and here more advanced, as they call, or specialized kind of metrics. And among them, FIB-4, which is a combination of these markers, basically age, some liver function test, and platelet count, is recommended as initial screening step. With that ELF score is recommended for subsequent steps. Again, referring back to this landmark paper that include 1,000 patients in there, the area under the curve for diagnosing fibrosis reach up to close to 90%, and that was primarily for the ELF test and for the fibrometer or FibroScan. Using what's called vibration controlled transient elastography. And we'll be looking into these momentarily. This is the FibroScan. It's basically a handheld probe that is going to be sending some sort of mechanical waves into the liver, and then receiving them back will get a quantification of stiffness of the organ, of the tissue that is passing through, and also it quantifies the liver fat fraction in there. Again, the FibroScan has diagnostic accuracy close to 90%, but it's primarily for stage 2 and 4 fibrosis, and there is modest performance for detection of earlier phases. One important fact about the FibroScan is that it suffers a little bit of reproducibility. So in same day, there are reports up to 37% difference in the values if the study is repeated in the same day for the same subject, and up to 32% if it's repeated in a different day. And this again from systemic from meta-analyses. One important note here is that when you say this tool is measuring stiffness, stiffness is not a direct measure of fibrosis. Stiffness could happen with inflammation, with even recent food intake, heart failure, hepatic congestion, cholestasis. All these lead to potentially erratic numbers of stiffness. And again, you can see from here, it's sampling a small area of the liver, and obesity is a nightmare for that device. The other modality is MRI, or in here, MRE, standing for magnetic resonance elastography. It is quite doing well for fibrosis. Again, overall diagnostic accuracy close to 90%. However, it falls back again for reproducibility, with up to 20% or 24% difference in the values between same day or different day repetition of the same test. Again, it is measuring stiffness. There's this mechanical driver that will send some mechanical waves through the liver, so the patient actually feels vibration kind of during the test, and then this will be translated back into elastography maps, basically like this, and we need to put regions of interest on some parametric images as shown in this figure. With all these steps, each of these phases probably is prone to some technical pitfalls. But the most important part is that both MRE and FibroScan struggle with early fibrosis stage, and they are measuring stiffness, which is not a direct measure of fibrosis. It's a surrogate, but it is not actually directly equivalent for fibrosis. This is again, I'm emphasizing the repeatability or reproducibility of the results of MRE and FibroScan. This showed high variability, could be overlapping with the response threshold that we will talk about later. So, seems like it's a complex disease, requires multidisciplinary, holistic strategy that involve multiple specialties, not only even healthcare. Probably you need more policymakers in here to try to cut short the what we have of the fast food and all these emulsifiers, artificial sweeteners, and comprehensive lifestyle interventions needed, up to bariatric surgery if needed for to control obesity. And part of the treatment should be aggressive management of any comorbidity. It was not till very recently, March 2024, when the first drug, resmetirom, was approved for liver fibrosis. And that's a very interesting drug because it's basically a thyroid hormone receptor beta agonist within the liver. So it's basically like accelerating the metabolism within the hepatocytes selectively. And the other drug that approved like a couple of months ago is the semaglutide, known for the brand name Ozempic, I guess. It is a GLP-1 receptor agonist that will control the glycemia and has been approved for steatohepatitis. Beyond these two drugs, there's more than 100 registered clinical trials. It's a very active area right now, active research area. And many of these drugs are in phase 2 and 3. So that leads to the question, if we get therapy, how you assess the treatment. And it's interesting to see that up to this moment, there is no established criteria for diagnosing response, for defining response, or for the duration of therapy. The most candidate will be the MRI proton density fat fraction as I mentioned, this is the gold standard for steatosis, for quantifying liver fat content, and they get a threshold of 30% as potential for defining response. Okay, so a summary of this long background. MASH LD or fatty liver is a prevalent global epidemic and not a simple benign disease. It's a leading cause of liver-related mortality, and there are specific treatments evolving right now. We have also some promising non-invasive tests for staging fibrosis, a hallmark within this disease, but they all struggle with early stages. They have wide reproducibility numbers, and there's no enough data on their performance after therapy. And generally speaking, biomarkers for inflammation, a stage that might coexist or precede fibrosis, are largely lacking. So with that introduction, we will get into the current journal paper that I selected. And that paper, as I mentioned, appeared in the European Journal of Nuclear Medicine, I guess, early last year, probably. And the authors are from a reputable medical college in Tongji Medical College in China. And they registered this study actually in 2020 on the clinicaltrials.gov, and they were aiming to enroll 100 patients, but the numbers that they publish are far less than that. And I was quite impressed by their opening sentence. They said the reversibility of early liver fibrosis highlights the need for improved early detection and monitoring techniques. And that, I guess, summarized that the current GAB quite well. The study is formed of two parts: a preclinical experiment aimed to visualize fibrosis in a preclinical model, and they supplement that with clinical studies for staging liver fibrosis using FAB and also other diagnostic methods. We'll start with their preclinical methods and results. This is an overview of what they performed. So I know probably the preclinical world is a little bit far from most of our practice, but basically they developed a mouse model of liver fibrosis, and that's using a carbon tetrachloride injection in intraperitoneal that will lead to liver injury and subsequent fibrosis. In the experimental arm, there are 34 and 26 in the control. All these animals underwent multiple, almost every 2 weeks, imaging and evaluation of biodistribution. And that took place 40 minutes after injection of FAB. And they start to quantify the uptake within the liver using liver regions of interest. They correlate that with the biochemical labs like the liver function ALT, ST, and hydroxyproline, and also with the immunohistochemistry of the FAB expression and other marker of smooth muscle. In their results, so each of these cornerstone method part, there's some results. They validate the model by seeing progressive damage of the liver and progressive fibrosis, and they also show FAB liver uptake that's notably higher in the experimental arm as expected, and the quantification of FAB within the liver was correlating well with both labs and FAB expression using immunohistochemistry. So that's primarily their setup. This is the animal model for the liver fibrosis. They use micro-PET, scan sequentially over 6 weeks, 8 weeks, and up to 12 weeks. And the control was injected also, but injected with like a placebo, basically olive oil. And that's their histopathological confirmation that the fibrosis is actually taking place in this model. And to the right here, there is images from a control mouse, and mice again are imaged with so this is the spine back, and this is the whole liver in there. This is a control, and you can see there is a minimal or no Fab uptake. And then the images over 6, 8 up to 12 weeks showing mostly progressive increase in Fab activity within the liver. It starts to decline a little bit towards the 12th week, and that's probably because more maturation of the fibrous tissue or development of cirrhosis in there. They showed quite great distinction for different metrics from the liver quantification. Again, they quantify mean uptake and maximum uptake. They quantify also the corrected uptake here by muscle background, and all these metrics show good distinction between each subsequent imaging phase. That leads to the clinical part of that paper. They enrolled 26 patients. 20 of them had biopsies. And they mentioned in their method that the uptake time was 21 minutes plus minus 11 minutes. That's to say some patients were imaged about 10 minutes probably post-injection, and some closer to 30 or 35 minutes. They quantified the liver using 3 liver ROIs and corrected that liver to the blood pool in probably in the descending aorta. And they looked into correlation and ROC analysis, which is again a value for quantitative metrics, varying for prediction of a certain outcome, varying between 0 and 1, with 1 being the optimum. So in their results, they also noted FAPI uptake, progressive uptake with increasing stage of fibrosis. They also have seen correlation with fibrosis, that's about 70% or 0.7 in there. And they have seen the overall accuracy for FibroScan done for these patients is about 86%, 87%, while that for FAB was close to 98%. And that's very important in these results, because that's for distinguishing between healthy and stage 1 fibrosis. So it's an early biomarker in here is probably evolving. They showed good example images in here. To the left here, this probably MIP scan of multiple sample patients of variable grades of inflammation and fibrosis. So they refer to the grade of inflammation using letter G and letter S for the stage of fibrosis. And they are mentioning also the corrected values for the average SUV mean corrected to the blood pool. And as you can see in here, the most interesting part of this image is not only the gradual increase in the liver uptake, but also that the liver, the background within the rest of the body is almost unchanged, which is important because as we know, some of the specific tracers, sometimes like DOTA-FAPI or PSMA, suffer from what's called sync phenomena, where if there is like very active disease somewhere, it starts to suck the tracer, and the target organ will, in here, the liver, might, and the background organ will not have enough or uptake similar to the standards. Again, they showed histopathological images for these sample patients, and they also overlaid the images on PET-MR. That was PET-MR acquisition, if I forgot to mention that. Looking through their supplement, they provide quite detailed overview of their patient cohorts. And what was striking to me is that it's quite heterogeneous group of patients in here. It's not a simple one disease that they are looking at, which complicates the results a little bit. So they have viral hepatitis, they have even overt cirrhosis, and about 11 of the 20 biopsies were early phases, like stage 0 or stage 1 fibrosis, which makes the recruitment favoring early fibrosis in here. And that, as you know, the diagnostic indices are affected by the prevalence of disease in here. Also, authors, I kind of late in the discussion, I start to recognize that the authors used a different grading system for inflammation and cirrhosis, inflammation and fibrosis, and that's explained why they describe 6 here that having cirrhosis, nevertheless their fibrosis stage was not 4, was less than 4 sometimes. Again, in the patient cohort, the quantitative results in here from the FAP liver activity. This is the maximum SUV max of the 3 ROIs. This is averaging the maximum of the 3 ROIs, and this is averaging them, and this is averaging of the maxima corrected to the blood pool, and similarly average of the mean corrected to the blood pool. All of them almost showing significant overlap between different stages. So the distinction here between stages is not as the clear separation that we have seen in the preclinical, in their animal model. Generally, the correlation was less for the inflammation and a little bit higher for the fibrosis. They also provide an extensive evaluation of the receiver operating characteristic curve in there. They showed different categories. For example, in inflammation, it performs up to 84%, which is better than most other the other net they mentioning here. And for fibrosis, the distinction between early versus the distinction between healthy versus stage 1 was close to 100%. That's quite surprising. It is quite high, and we'll get into that a little bit later, because basically they get this AUC, and they get some cutoff values for defining the best or optimal cutoff point in the same cohort. It's generally not a good practice to extract a cutoff from a cohort and apply it directly to the same cohort. You would like to validate that in either independent cohort from that same, like basically dividing your cohort into one for testing and another for validation, or you would like also to do that even more optimally in an external validation cohort that was acquired probably in a different institution under different protocols, to make sure that what you are seeing is really valid across different techniques. The authors also appropriately describe prior case reports, just visualizing cirrhosis using FAP, and also the cite a prior animal model in pigs, and in the pig model, it's important to make this distinction, because in the pig model you cannot have the F1 stage because of the nature of the model itself. So, but they show visualize separation between the late stages and early stages. what I hope to see in their discussion is the discussion of potential use for therapy, because there is evolving evidence, might not be in the liver domain, but in the cardiac domain, in the hypertension model, if that FAPI PET signal can be a good surrogate, early surrogate for response. Basically, you see FAPI uptake when there's hypertension, and when the cause of hypertension is withdrawn, there's a drop of FAP signal within 3 days. That's quite rapid response. And yes, that's an animal model, but it's quite promising result to translate into human. So the authors mentioned study limitations for their animal model, as mentioned. There's a little bit of variability you can imagine for animal models, and they suggest that there could be other models like bile duct ligation, and also could include a knockout of FAB as a negative control. They also acknowledge that the biopsies were performed only in 20 out of the 26, which is quite good number for if you consider liver. And they also use the Chinese grading system, which makes things a little bit hard to compare to international studies. And although they had MRI, they didn't use it enough for this study. So basically, if you have MRI, I'm assuming it's a full-blown MRI, you can have MR elastography probably, or even MR proton density fat fraction, but these all were not there. Additionally, that was not directly or directly mentioned by the authors. There are some statistical considerations that we kind of mentioned about them during the results. First, they did not mention about the normality of data distribution, and they just assume in normality probably and start using some parametric statistical testing. They did a lot of multiple comparisons here, and in the statistics, if you are doing multiple comparison, you need to correct that to avoid false discovery. This also was not mentioned. And they, as I mentioned earlier, they used cutoff from ROC and apply it within the same cohort, which is not the best practice. On the biological side, they have a little bit of uneven uptake time. So if you remember, the animal model was imaged starting at 40 minutes post-injection, and that compared to in the human was 21 plus 11 minutes. And that's a little bit of gap in here. So I couldn't understand the reason behind it. And they didn't explain why that. And you expect that there is some evolving evidence that FAB might be washing out. Even in some cancers, they might be washing out, and there's an optimal window that you would like to capture your tracer. And the other major part, I think they indirectly mentioned by in their limitations, but this is quite heterogeneous population. And no surprise that they could not see a clear distinction between stages, because they are involving multiple different causes of fibrosis, not a single cause, including viral hepatitis and also including cirrhosis. With that, I will go briefly through a current work that we actually have the preliminary results of for this study, led by Dr. Shivani and supervised by Dr. Ramzi Badawi, the co-inventor and the director of the Explora Molecular Imaging Center. We used a little bit different FAB tracer in here. This is labeled to labeled to fluoride, not to gallium-68. And the cohort is not big. This pilot study with 10 subjects were imaged dynamically for 60 minutes. And these preliminary results were recently presented in the ENM. And what we have seen is that early imaging SUV images at 5 minutes corrected to the blood pool were quite a good discriminator between different stages. Here we divide them by healthy, and early stages fibrosis stage 1 and 2, and fibrosis stage 3 and 4. And although you can look at the p-values, of course, and see that's not significant, but what's more important is the distribution that you see and the kind of separation that you can see between the groups. And in here, the reported correlation with the stage, with the fibrosis stage, was 0.94. That's again compared to the previous result of the study that we just mentioned was 0.6 or 0.7. That also was true for a more sophisticated metric called the KI. It's KI is it stands for the net influx rate. It's considering more the whole duration of the acquisition in here, not only at the 5-minute. And that KI also has a good correlation with fibrosis stage. So that could summarize in here the advantages of FAB. That is probably you can guess not affected by sampling error. You can see the whole liver. You can draw regions of interest on all the different parts of the liver, and compared to other non-invasive testing that might suffer in the presence of obesity or ascites. That is not the case with FAB. Also, the advantage of FAB being a direct marker of the activated hepatic stellate cell. And that makes it a good early marker for fibrosis. I'm wondering if we can, in the near future, see how it is being used to select, for example, stages 2 and 3, which are the current indication for treatment, versus stage 1 that is not yet approved for early treatments, or even expanding that beyond that to between the healthy and early, very early fibrosis stage like F1. We also capture the whole body, so you have a potential to capture the inter-organ connectivity and other comorbidities like myocardial fibrosis, for example. FAPI also has the advantage of ready-made kits that are available. If you have a gallium generator, you could use it on site. And there are also available labels for technetium. So you can also use that on a SPECT machine. You don't necessarily need a PET, sophisticated PET machine or even a gallium generator. The other side of the story, you might suffer a lot of limitations as well. One thing that FAB is being developed by multiple companies, not a single tracer, not a single ligand in here. So there's different ligands similar to the development PSMA. If we remember early, there are multiple flavors of PSMA. They differ a little bit in their biodistribution and their performance. So that should be taken into consideration to standardize and to quantify these differences. Also, the advantage and disadvantage of being a cellular marker is that we are not measuring fibrosis directly as well. We are measuring the activated hepatic stellate cell expression of FAB, but not directly measuring the fibrotic part, fibrotic niche itself, that's formed more of collagen, fibronectin, elastin. This is devoid of cells. This is already the laid down matrix. And that makes me wonder if there is a potential for combining the strength of both PET and MRI, specifically the elastography techniques, because they excel in detecting more of this fibrous tissue. The other limitation of FAB is the weaker or unclear association with inflammation, and that makes the next stage whether or not FDG can detect MASH. We know FDG is a good inflammation marker. And however, there were contradictory results regarding its performance for MASH and hepatic steatosis. A group here at UC Davis, led by Dr. Wang and Dr. Sarkar, published pilot work, 46 patients, where they show that SUV or KI showed no discrimination between inflammation versus no-inflammation. However, if they use the delivery rate, it's called K1, it's one of the parameters that you get from dynamic imaging. you can get an overall accuracy close to 90%. And that's quite astonishing, knowing that most of the MASH biomarkers now are performing far less than that. And it's not necessarily that you have the 60-minute, and not necessarily also to have a total body to perform that. There's a recent evidence that even with shortened dynamic acquisition of 15 minutes, either on a total body or a conventional path, you can still obtain the K1 robustly, and also can make the distinction between inflammation and no inflammation. So again, take-home message from here: MAS LD or fatty liver is quite prevalent. It's not a simple benign disease. It's a leading cause of liver-related mortality, and specific treatments are evolving. Most of the current non-invasive diagnostic tests are suffered a little bit in the early stages, and they have wide reproducibility figures, and there's no data on their performance after therapy. The MASH or inflammation biomarker are largely lacking, an area where FAPI or FDG could fill this gap. We're looking forward to see head-to-head trials against other NIT imaging studies, different indications, staging, response assessment, and others. And we would like to see also what would be the whole body story beyond the liver. What can tell us? Mentioning that we know that there's a lot of logistic in implementing a FAB program, and that needs a lot of resources and also a lot of collaboration with the relevant department and relevant teams. And with that, I guess I stop in here, and thank you all, and I'm glad to take any questions.
شكرا جدا دكتور ياسر على المحاضرة الجميلة جدا ديت. فتحت عينينا على موضوع احنا شايفينه كتير حوالينا بس مش عارفين أهميته. تمام. وحقيقة يعني موضوع لطيف جدا. أنا هنا كان ليا سؤالين. أول حاجة، هل الفابي كان الديستريبيوشن بتاعه في الليفر كان هوموجينوس، معنى كده إنه كل الليفر بيبقى ديزيز ديجري واحدة، ولا مالتيبل ديجريز؟ المشكلة اللي هنقول عليها في السامبلينج ايرور، ان احنا كده عندنا ممكن يكون في اختلافات بين المناطق اللي بناخد منها سامبل. هل ده كان باين في الفابي؟ تاني سؤال،
اتفضل.
هل الفابي هيبقى ليه دور في الفولو اب بتاع الاوزمبيك؟ فده ممكن يبقى ليه كده، يبقى حتى يبقى يعني مدفوع ثمنه مع الاوزمبيك اذا كان هو الاوزمبيك تريتمنت يعني.
تمام. أجاوب السؤال الأولاني. What is known is that MAS LD is likely a diffuse disease. So there's a good chance that it is homogeneous across the whole liver. At least for MAS LD, we don't know about viral hepatitis. It could be different a little bit, but this is still evolving. The second question, yes, يعني اتمنى طبعا يكون ليه دور، لكن حاليا لو احنا بنتكلم على approvals, FAB is early on, and it's not even approved for cancers yet. There's I think the company called Sophie, I guess, they are sponsoring a study, phase 3 study for cancers, but beyond the cancer, I guess it is still a little bit long path to see that in the clinic.
دكتور محمد عبد الرازق اتفضل. استاذ محمد استاذنك افتح المايك.
مساء الخير عليكم. First of all, I would like to congratulate you, Dr. Waleed and Dr. May, for professor degree. You deserve it, and deserve more, even with more success, as you show all and promised, and sorry, showing this great manner for in nuclear medicine. We are proud of you all, guys.
Thank you very much.
You are welcome. Also, my question is to Dr. Yasser. Welcome, Prof. Yasser. It's a really marvelous presentation. Of course, it's a great project. And I have two questions, Dr. Yasser. Regarding the degree of chronic inflammation, as stated in the preclinical studies, after carbon tetrachloride injury, the Fab uptake was maximum, as you know, almost 10 weeks. It starts 6
Yes.
weeks, 10 weeks, and then becomes reduced after 12 weeks. Is it true?
Right.
Hello?
Right.
Okay, great. Then this, and you stated that the correlation with fibrosis is more with the chronic inflammation. But it actually, as I understood, the reverse has been shown in preclinical studies by that finding, which is maximum almost 10 weeks, and then becomes reduced when fibrosis established, as I think. This is my first question. The second question is the correlation, as you stated, there is correlation with the muscle. I mean, the ratios of SUV uptake, as muscle is an indicator of fat content of the liver, as we know all, particularly on MRI, not on CT in particular, but maybe also on CT is true. Why they are not doing this correlation with the CAB, which is, as you mentioned, the CAB parameter for fatty infiltration? Why they didn't do this corrected ratio? Those are two questions. Thank you very much.
Thanks, Dr. Mohammed. Thank you so much for the questions. I'll start with the first one about the animal model. Yes, so all these are showing evidence of fibrosis, as you can see from the histopathology in here. But it reached a maximum here at 10 weeks and start to decline. The uptake start to decline. Fibrosis did not decline. This is a very important distinction. I guess the authors attributed that to the transition of the model into frank cirrhosis. So two things. One, the animal model is not really reflective of the human studies. Second part, from what I have seen in the literature, and I mentioned that it might be a little bit of limitation for FAP itself, is that it goes where the start of fibrosis is taking place. This is the activated hepatic stellate cell, and slowly it will basically be laying down huge matrix, probably huge extracellular matrix that is mature fibrous tissue, and that part is not cellular itself. This so it really depends where we are looking into this part. We are looking at the hepatic stellate cell. We are not looking at the fibrosis directly. So that a little bit could explain why there is lack of uptake in here.
Okay,
but this is very important note. Second part, I'm not sure I get the question correctly. Are we asking about why they didn't correlate that to CAP or?
Yeah, the SUV. I mean SUV to CAP.
So they didn't
because they did it with the muscle. Sorry for interruption. Okay.
Oh no, it's totally fine. So they did not actually. They did not make a correlation with the muscle. They in here so
as I remember, Dr. Yasser, you commented on the one table, the SUV ratio
this
to the
is
muscle.
the preclinical model. They corrected some of the background to the muscle. We're talking about skeletal muscle. In the human, they do that in respect to the blood pool measured in the I think descending aorta. That's one.
Now this is usual in all, even in oncology, but I mean here in particular. They correlated one parameter to the muscle, because muscle is the measure for grade of fat, I think because of the attenuation coefficient.
So if the question is regarding the liver stiffness measurement, they actually reported that, and they reported that it's showing better accuracy in higher stages of fibrosis. So they have this part of the results already mentioned in their discussion and results as well.
Okay. But do you think if the correction is done with CAB, it will be different?
So what do we mean by correction?
I mean the CAP as an indicator for the attenuation coefficient for fat in order to segregate the fat from fibrosis or I mean activated stellate cell, for example,
I see your
for
point.
the SUV to be more accurate.
I see your point. So FAP is, as you know, is not really an indicator of steatosis itself. We're measuring 3 parts in here for mass LD. We're measuring steatosis, we're measuring inflammation, and we are measuring fibrosis. And FAP only will be looking at that. So there is no surprise that probably you see less correlation with steatosis itself, with status measure of CAP. They did not mention CAP. Yes, I agree with you. They did not mention the steatosis part in their human study. But you can see probably inflammation. The correlation with inflammation was much lower compared to the correlation with, I think the next slide probably.
Okay.
The correlation with the inflammation was much lower compared to the correlation with fibrosis. Perfect.
Okay, thank you very much. Thank you.
Thank you.
دكتور خالد اتفضل. استاذ محمد استاذنك افتح للدكتور خالد طلب.
شكرا يا دكتور ياسر على المحاضرة الجميلة ديت. محاضرة very concise و comprehensive and insightful. عندي كم سؤال أو ملحوظة كده حضرتك تعلق لي عليهم. أنا بس بتكلم برضو إحنا مشكلتنا دايما النيوكلير ميديسن ستاديز إن إحنا السنسيتيفيتي بتاعتنا دايما بتبقى عالية والسبيسيفيستي دايما بتبقى very low. انا برضو دي مشكله احنا مش هنقدر نتخلص منها خالص. يعني دي مشكله عامه وحتى انها موجوده معانا على طول الا في حاجات في in certain conditions or certain يعني studies يعني. فدي حاجه انا برضو حاسس انها دي هتبقى موجوده برضو ملازمه للفابي في الستاديز بتاعتنا. الحاجه الثانيه البيبر اللي احنا كنا بنتكلم فيها دلوقتي السامبل سايز 60 حاله 60 16 26 يعني 26 و30 تقريبا. انا كنت مش فاكر الرقم بالظبط بس انا قصدي السامبل سايز ده في حاجه بتحصل تقريبا 1 ان بتوين 3. دي حاجه برضو مش ممكنه. لما نعمل برضو نرجع كده لورا سنه صغيره ونعمل اكسترابوليشن للستادي دي عندنا في مصر احنا مشكلتنا اتش سي في اكتر من انها اتش بي في. اتش سي في برضو احنا الشغل بتاع كل الار ان ايه فيروسز مختلف كومبليتلي عن الدي ان ايه فيروسز. فانا قصدي في شويه حاجات كده كتيره قوي. الاستادي طبعا دي احنا اللي عاملينها يعني. بس انا بتكلم ان احنا برضو احنا لازم نبقى نعمل حاجه تخصنا لان احنا فعلا في فرق جامد جدا ابيديميولوجيكالي ما بين حتى انا الماب اللي حضرتك عملتها الجي اي اس اللي انت صورتها لنا دي مصر الصوره بتاعت مصر زيها زي مثلا جنوب امريكا الجنوبيه زيها زي حاجه في جنوب شرق اسيا. فانا قصدي احنا حتى الجينوتايبنج بتاعنا كومبليتلي يعني مختلف خالص. يعني اللون الازرق ده عامل زي امريكا الجنوبيه موجود حاجه في جنوب شرق اسيا حاجه فتفوته كده صغيره اللون الغامق دوت في حاجه في المكسيك. فاحنا حتى الجينوتايب بتاع الماسل بتاعنا او المافلد بقى ماسل كومبليتلي. فهل تتوقع ان مع هذا الانيشال او البريمتيف ريزلتس بتاعت الاستادي اللي موجوده دي could be extrapolated للشغل بتاعنا احنا والحالات بتاعتنا احنا خصوصا برضو ان احنا الاوبستي عندنا يعني very very evident يعني الناس عندنا برضو في مال براكتس في استخدام الادويه دي ممكن تعمل اصلا عايز اقول يعني كونفاوندنج اي ريزلت. يعني ممكن تربك اي ريزلت. فالكونفاوندرز الكتيره اللي عندنا بالموربيديتي اللي عندنا بالإيميديبيولوجي اللي عندنا بالجينيتيك باك جراوند بتاعتنا هل الكلام ده نقدر ناخد كوبي بيست ونشتغل؟ ده سؤالي لحضرتك. بس انا سعيد جدا جدا بالكونسايز يعني برزنتيشن اللي فتحت حاجات كتير قوي قدام الواحد يعني. شكرا يا حبيبي ربنا يكرمك.
شكرا لحضرتك يا دكتور خالد. ملاحظات غايه في الاهميه وفيري انسايتفول الحقيقه. اول حاجه انا متفق مع حضرتك تماما. it's very early for FAP to think even it could be a biomarker for a specific biomarker for fibrosis in here. احنا بنتكلم على disease ممكن ال current criteria as we discussed allow the coexistence of other conditions. So مثلا دي ممكن يبقى موجود في وجود hepatitis C، ممكن يبقى موجود في وجود hepatitis B، ممكن يبقى موجود في وجود حاجات تانية زي even alcoholic liver disease and others. Would it lead finally to similar pattern phenotype in the imaging itself? We don't have data at the moment. It might be disease specific, course specific, might relate to what current stage of the viral load, viral genotype as you pointed out, Dr. Khalid. كل الحاجات ديت need to be discovered, need to develop our own experience. Definitely, it's not gonna be a copy paste, because I do believe that even assuming that it is exactly the same disease, it's different between our genetics and their genetics. So probably that's need to be a good study in the future for Egypt. Maybe even a national kind of study basically. مشروع قومي كده تاني زي المشروع اللي اتعمل مع الهيباتيتس سي والحاجات دي. شكرا دكتور خالد، سؤال حضرتك.
ألف شكر، شكرا دكتور ياسر.
شكرا جزيلا دكتور ياسر على الردود الواضحة. وطبعا لو حد تاني عنده أسئلة يتفضل يبعتها على الشات. سعداء جدا دكتور ياسر بوجودك معانا النهاردة، وإن شاء الله نكررها في محاضرات تانية أوقات تانية كتير. تمام، شكرا جدا لاختيارك المحاضرة ديت أو البيبر ديت، لأنها حقيقة بيبر ممكن تفتح لنا باب جديد إحنا لسه مش شفناهوش قبل كده. وإن شاء الله دايما كده يا جماعة متجمعين في محاضرات تانية كتيرة مع أساتذة وفرسان للنيوكلير ميديسين موجودين في مصر وخارج مصر إن شاء الله.